Hi, my name is Jennifer Lightdale, and I am going to give a talk on identifying liver disease in obese children. Now what to do? I have no faculty disclosures related to this talk. So I'm, of course, going to talk about a massive issue, so to speak, which is childhood obesity. It does involve at least a third of all children and adolescents in the world, and particularly in the United States. And we do believe that childhood obesity has more than tripled over the past 30 years. And of course, overweight adolescents have a 70% chance of becoming overweight adults. So there's real concern here that we need to get on top of this problem. And it really is a medical disease that involves a number of medical complications. From a GI perspective, we get directly involved because it can involve severe pancreatitis and gallbladder disease. But perhaps the biggest issue is this non-alcoholic fatty liver disease, which encompasses steatosis, steatohepatitis, and cirrhosis. So the AAP has been certainly interested in helping pediatricians to know what to do when they encounter an overweight or obese child. They've sort of divided this into two groups that need to be thinking about it. The first were really primary care clinicians, and they gave a whole number of labs that you could consider doing. There's no mandating here, but really consider doing in primary care settings, laboratory assessments around obesity. And they really focused on getting a lipid panel, AST and ALT as common liver enzymes to understand those levels, and a fasting glucose level. And they also said, well, what should you do if some of these are elevated? So of course, there's a whole number of tests you can do because there are all these different complications. But in terms of the liver test, they really say, look, if you're a subspecialist, that's when you should move forward. And they give a whole host of other tests to think about. But they really have put that into the realm of the subspecialists. So if you think about this, and you think about the fact that so many children are overweight, and the chances that you're going to find liver issues if you start looking for them is actually quite high. I think they've created a sort of deer in the headlights phenomena where the pediatrician really feels not sure what to do once they find the liver enzymes, and they're sort of put in the position of referring to the specialist. And I'm on a personal mission, and the AAP is indulging this, that I really want to demystify this all for you so you can feel confident, you can understand what those labs mean and actually what you're supposed to be doing next. And it isn't all just about referring to the specialist. So let's start by talking about non-alcoholic fatty liver disease, or the so-called NAFLD, which is really the most common of all liver disorders that we see with obesity. And it's a very frequent cause, in fact, the most frequent cause of chronic liver disease among people. It is generally asymptomatic. So you're obese, we think you're at high risk for NAFLD, but you generally don't have any symptoms of it. And it's very, very common. So 3 to 20% of the general population, at least 75% of individuals with obesity and type 2 diabetes. In children, if you just take all children, it's about 9% of children, and 3% of those will have the non-alcoholic steatohepatitis, which I'll talk more about. But this is all comers, and actually, if you look at obese children, it's really more than 50% that will have NAFLD. And the most important thing of all about NAFLD is to recognize that it is a reversible condition. You really want to see it as something you're supposed to do something about, because you can treat it and you can make somebody not have NAFLD. So, there's just nothing about trends in obesity among children and adolescents in the United States that really makes us feel that we are significantly affecting the curves. And this is showing data up until 2008. There's been a little bit of some stabilization, but the bottom line is it's been on the up and up. And we really feel, if you look for prevalence of liver disease in the United States, again, it's incredibly common. We think NAFLD is about 20%. The steatohepatitis, NASH, is about 3%. That's much higher than chronic hepatitis C, which comes in next at 2%. Alcoholic liver disease is really in the minority at 0.7%, and chronic hepatitis B is bringing up the rear at 0.4%. So really, this obesity epidemic is the epidemic of liver disease. When we use the term NAFLD, it really is a broad term. So it's encompassing the concept of steatosis, or fat in the organ itself, steatosis with inflammation, steatohepatitis, where you actually have a hepatitis going on, irritation and inflammation, and cirrhosis, where the liver has really been injured to the point of death. And we'll look at that. NAFLD and NASH are really not interchangeable terms. You can have a lot of fat in the organ, but not necessarily have inflammation going on. NASH, the inflammation, is a much more serious complication of childhood obesity, and it can lead to end-stage liver disease. But more likely, it's something that a child will carry on into adulthood, and over time, the liver will start to become cirrhotic and die. And so it's now thought that NASH in childhood is probably the most common cause of cryptogenic cirrhosis in adults. The other thing we've learned is this real link between NAFLD, insulin resistance, and metabolic syndrome. So it's not completely understood, but it is felt that NAFLD basically over time can lend itself in the right milieu to steatohepatitis. And it's part of the metabolic syndrome. So the concepts here is you have insulin resistance and the metabolic syndrome. You have impaired insulin, which actually is a mediator of lipolysis. So you have less suppression of lipolysis, increased fatty acids, which now start to have sort of this vicious cycle effect. And over all of this, you wind up with lots of fat in the liver as part of the metabolic syndrome. So, you know, when you look at it from a gross and histologic standpoint, I think it's actually the most helpful from a visual standpoint. And sometimes I will show this slide to my patients. But basically, a nice normal liver is a dull and healthy looking red. And if you look at the hepatocytes, they're nicely organized. And it actually looks pretty dense as an organ goes. As you get into fatty liver, it actually looks like a fatty chicken. And I say, you know, think of it like a raw chicken. You're going to see all this fattiness on the outside of the liver. And indeed, under the microscope, you're seeing these large vacuoles of fat. This is steatosis. And what's really important to know is if you change the degree of fat in the blood, and literally you decrease the obesity, you can get reversal. And it's really important for children to visualize that, for parents to visualize that, and to understand it. Unfortunately, once you have steatosis, again, we know something sort of triggers it to cause some inflammation and irritation. And it's not all the time, but in a good percent of the kids, you will have this change where you have inflammation and fibrosis going on, which really under the microscope stains blue as opposed to the rest of the healthy liver or even the fatty liver. When you start to get the blue staining, what you're seeing here, that's fibrosis. And if you go all the way to the end to cirrhosis, you really have what's called bridging fibrosis, and you're starting to have a very unhealthy looking liver. So the two-hit hypothesis is really that the fatty liver is the first hit, and there's something about then some genetics probably and susceptibility, and probably a second hit of oxidative stress or toxins or inflammatory molecules that leads to damage of the liver. So not everyone with steatosis goes on to get steatohepatitis, but certainly you need the steatosis to have that happen. So a big thing going on with an unhealthy liver is apoptosis is happening, which is basically cell death. So the cells really being driven essentially to die. And it's this hepatocyte apoptosis that we see increased in patients with NASH, and then really is the way, if one goes on and having lots of steatohepatitis and apoptosis, that's actually what leads you to this very scarred looking injured liver of cirrhosis. So, you know, what clinical features of NASH, assuming you're not going to enucleate somebody's liver or necessarily always do a biopsy, and I'll talk a little bit about that because we don't always do biopsies. The truth is, from a symptomatic standpoint, most kids are asymptomatic with NASH. There really are no specific symptoms involved. You often, but not always, find hepatomegaly, and sometimes there's evidence of portal hypertension where you have splenomegaly. Often the liver enzymes are elevated, but they may not be as high as you expect. So, but 2 to 3 times normal is usually what we'll see. You may see elevation of GGT, and you may see abnormal synthetic function with an abnormal PT or INR. And really on the ultrasound, you're seeing the size of the liver very objectively, and you're seeing this increased echogenicity. So it's really the ultrasound that you start to say, maybe this is NASH. So what's so important about the liver? This is another important thing for, I think, all clinicians to really understand and to impart to their patients, because I think the liver is one of those organs nobody really understands. So first off, it is your largest internal organ. And secondly, it's really important. And one way you know it's important is it has this dual blood supply. So it's got portal vein that's bringing venous blood from the intestines and the spleen. And then you also have the hepatic artery rising from the celiac axis, all bringing blood through the liver. So lots of blood going through the liver. And that's because the liver has a lot of functions to perform basically on our blood supply, on what's circulating throughout our body. It really has more functions than any other organ. And it's big, it's a big organ, and it can sustain life when a lot of it is dead. So the good news is you sort of have this big battery and you can really ruin a lot of it. But it's still, you don't want to be doing that. You really want your liver functioning for you. So, in terms of breaking down those functions, so to speak, the liver is really important for purifying what's in our blood. So it's basically breaking down any potentially harmful chemicals into stuff that's less harmful. And of course, the way we know about this most is it basically purifies all the drugs, or it breaks down drugs. They're all many of them are hepatically metabolized. The other thing the liver does is it synthesizes proteins. It actually makes most of the proteins found in blood. Importantly, albumin, and also all of the clotting factors that are necessary for coagulation. So those are very important proteins, but it basically makes most of the proteins found in the blood. It synthesizes and excretes bile, which you need for digestion. And it's a big storage organ. So it's got a lot of space in it, and it's going to store what you might need later, even if you don't need it right then. So it's sugars, fats, vitamins, those are all stored in the liver. And then the liver is also important for transforming things. So what does it transform? It transforms hormones. It also transforms, it breaks down and synthesizes cholesterol. And it's also synthesizing proteins. And to do that, it's really using enzymes. And the most classic enzymes are aspartate aminotransferase, or AST, and alanine aminotransferase, or ALT. So, these are enzymes that the liver is using to synthesize proteins. So these aminotransferases are most widely ordered liver chemistries. And when you see them go up, it means that the liver has been injured. And the ALT is more likely to only reflect liver injury. The AST is a little bit more widespread, so you're going to see it in cardiac skeletal tissue, kidney, brain tissue, but it's really mostly in the liver. So AST and ALT, when they go up, that implies that there's been injury to the liver, and you're seeing those enzymes now in the blood. A little bit of difference in terms of where they're found. So ALT predominantly localizes to the cytosol, AST to the mitochondria. But when you have death of hepatocytes, so when you have apoptosis and then sometimes necrosis, that is when you're seeing elevations of them. And really, thinking about, well, what level of elevation am I seeing, is helpful for distinguishing acute and chronic liver diseases. So when they're somewhat elevated, 2 to 3 times upper limit of normal, but are not too high, moderately high, usually less than 300, that's when we're thinking NAFLD, NASH. It's one of the chronic hepatitis. When you have much higher than 500 and even up to 5,000, you're thinking acute injury. So it could be acute viral hepatitis or autoimmune hepatitis or a drug reaction. And really, when you get above 5,000, that's when you're in failure. And we'll often see that in pediatrics with this acetaminophen toxicity. So AST-ALT ratio is something people talk about, and the bottom line is it's going to be less than 1 for most hepatocellular injury. In adults, if it's greater than 2, sometimes that's a signal that it could be alcoholic liver injury. And then AST is always going to be higher in cirrhotic patients, regardless of the etiology of liver disease. So sort of looking at those numbers related to each other does give you a hint as to what's going on. So, we call them liver function tests, but that's really a misnomer. They are not true tests of function. They're just telling you that the hepatocytes have been damaged. And really, true liver tests are not widely used. So that would be like galactose clearance or aminopyrine clearance tests. But I think what the abnormal liver enzymes are often is the first indication that something is wrong with the liver. And of course, what's important to know is even if you don't see them elevated, that doesn't mean you don't have liver disease. Sometimes the liver is so dead in a totally cirrhotic liver, there's no more enzyme to be elevated. So that the numbers will actually be normal or even low. Okay, so what do you do when you find elevated AST or ALT in your obese patient? And, I think, again, the guidelines say you should go looking for it. So the first thing is you should not panic. You should have confidence. You should understand, I saw a child, they looked obese. I got the enzymes, and I am wondering if they are in trouble with their liver. And the answer is yes, they are. But the other thing you have to do is say, well, they look obese. I'm fairly sure what I'm seeing would be consistent with the liver disease I thought they might have. But you should also think about any other reason that they might have liver disease, because just because they're obese, that doesn't protect them from other reasons. So we'll talk about that. The other thing you want to be doing is assessing the degree of liver injury. And to do that, you actually want to try to understand their function, so the liver function testing and whether the liver is functioning. You certainly want to educate the patient. It's not enough just to get the elevated numbers and send them in. You can't tell you how many patients I see who I say, why are you here? And I'm looking at this incredibly obese child, often sitting next to two incredibly obese parents, and they say, we don't know, the doctor sent us in. So that's not helpful. You need to tell them, I got this because I thought you were obese, and I was worried about your liver, and I was correct. So you need to educate them about that. And then very importantly, you may not get into me for 6 weeks. That's 6 weeks of the child continuing to eat and really not have a lifestyle that is treating their obesity. So it's really important, and I think pediatricians are very good at this. You want to treat the obesity. You have to tell them, we have to do something about your obesity. It is affecting your liver. All right, so I'm going to take us into what they said should be considered by the subspecialist, but my contention is you can do this too. And in fact, the more you do this, the more you're actually sending me a patient that I can help you with, as opposed to I'm telling them we need to deal with your obesity, which feels kind of funny. So the first thing we do when we encounter NAFLD in children, so the child who was sent into me because they found the elevated AST, ALT, is I say, well, could there be any other reason for this liver disease? And I want to think about this because I don't want to just assume that it is due to the obesity. And so I'm thinking about hepatitis, A, B, and C. I'm thinking about Wilson's disease, which we'll talk more about. There's something called lysosomal acid lipase deficiency, which you'll usually know about in a newborn, but there's some subtler forms that can keep going. There are a lot of endocrinopathies. So you have to think about diabetes, in particular type 2 diabetes. You have to think about thyroid conditions. Mitochondrial disorder is less common, but to think about autoimmune disease, again, usually is going to give you a much more profound hepatitis, and it's actually going to be a totally different presentation, but it's still something to consider. And then there's something called alpha-1 antitrypsin deficiency, which is loss of alpha-1 antitrypsin. Again, usually you've known about this, but sometimes you just want to be sure that you have thought about all these. And the tricky thing to all of these conditions is that they are mostly asymptomatic until the liver dies. So really you can't go asking if you have any symptoms of these, you just need to check for them. So I'm going to focus for a minute on Wilson's and lysosomal acid lipase deficiency. Wilson's disease is a fascinating condition. It's really an inherited disorder of biliary excretion of copper. And you get this accumulation of copper and in lots of places, your brain, your liver, your cornea, your heart, your kidneys, your pancreas. And we estimate it's about 3 to 30 in 1 million individuals. And it's really a genetic mutation of the ATP7B gene. And that's important for a copper transporter. So, and the key to Wilson's disease, if you're missing that copper transporting ATPase, is it's completely treatable. And you can use chelating agents, and we really have penicillamine in younger kids and tretinoin in older kids that we tend to use. But it is really treatable. You just want to know that you have it. Of course, the more I think families have discovered this gene, you'll have genetic profiling going on early on in families where it may be passed down, but certainly it can be detected sporadically. When it presents in an unknown situation, it's intriguingly usually psychiatric or neurological symptoms from accumulation in the brain. And this is sort of classically the adolescent who's being misdiagnosed as having a schizophrenic breakdown, where they're really sort of manifesting what looks like some sort of bipolar or mood disorder or just flat out schizophrenia at a classic age for that to develop. And you just want to be thinking, gee, could it actually be something accumulating in their brain, especially if they've been normal up until this point. And they sort of classically have these Kaiser-Fleischer rings, which is the copper in the cornea. And it's very classic labs you see. You see this decreased serum ceruloplasmin, and you see increased urinary copper because they're just spilling all this copper into their urine. And then on the liver biopsy, you'll see something that looks like NAFLD or NASH, but certainly shows a lot of inflammation. So these are Kaiser-Fleischer rings. You're seeing the copper around the blue. You can see it around brown eyes too, and certainly around green. So there are other reasons one could have Kaiser-Fleischer rings, but they should be something one thinks about if you're noticing that. Okay, what about lysosomal acid lipase deficiency? So these are really rare genetic diseases, and you're getting accumulation of cholesterol esters and triglycerides. And most people with LAL deficiency are going to present in the neonatal period with really a severe presentation called Wolman's disease that sort of classically has beyond the liver and the failure to thrive and not well, they have adrenal calcifications. But there are some milder variants that we're learning more about, and in particular, cholesterol ester storage disease, again, looks very similar to NAFLD, just a fatty steatosis, just fat in the organ itself. And so, you have to be thinking about this and to test for it. So, what else do you want to do when you think about liver disease? You want to get true tests of liver function. Not just AST, ALT. Basically, you're looking to see if the liver can synthesize proteins. And really, the best is to be thinking about albumin, which is exclusively synthesized by the liver, has a circulating half-life of about 3 weeks. So if you're seeing elevated AST, ALT, and a reduction in albumin less than 3.5, but certainly less than 3, that's when you've had a chronic liver disease going on for more than 3 weeks duration, and the liver is just not synthesizing albumin. And then PT will be elevated. And again, that's because they're coagulation factors, which are exclusively synthesized in the liver. So, how do you remember all of these labs? So the answer is I don't. I suggest everybody use a provider checklist. And this makes sure, again, these are asymptomatic conditions. Having one does not protect you from not getting the others. You really need to think about them all. So I use a provider checklist. It ensures a standard approach to every patient I'm seeing. It avoids my trying to judge, oh, this looks like a family who wouldn't have, there's just no way to say they won't have Wilson's disease or won't have hepatitis. You actually can't say that. So it's particularly difficult though, I think, because I think we tend not to draw a lot of labs, but I will tell you, when you get this many labs, it gets the patient's attention. And this is actually the checklist I use. So I'm giving it to you here. And these have been, well publicized. This is, I think, pretty much straight off up to date, where I'm literally going to get all of these labs, thinking about all of those conditions that I listed out. I always get an abdominal ultrasound, and I will tell you, I do this in one go, and it really drives home the point that I am worried about your liver, and I'm going to check a whole bunch of labs and make sure I understand what's going on with you. But remember, most of what you're doing is just ruling out anything else. In terms of the abdominal ultrasound, no Doppler is necessary. Your goal is just to assess the size of the liver, and also to look for splenomegaly. And really, it's looking for increased echogenicity, which we see with fatty infiltrate. So it's a normal liver, which looks very homogeneous. And here's NAFLD, and you're just seeing what they call the starry sky, just a brightness to the liver. So what about a liver biopsy? So, there's actually not great guidelines on when one should do a liver biopsy. You can do a liver biopsy, and always, it just comes with a lot of risks, particularly risks of bleeding. The liver is a very vascular organ, and inevitably you'll have blood when you do a liver biopsy. I think it does help you to say, well, am I dealing with NAFLD, just the fat in the liver, or do I have inflammation, the blue staining that you'll see with fibrosis? Do you have bridging fibrosis, which you'll see with cirrhosis? So that's the degree. And arguments against, really, there's the risks of it, the costs of it. What's fascinating is there's really nothing you're going to do differently. You're going to draw all those labs, and you're going to tell the patient to lose weight. So it doesn't really change your disease management. And the other thing I think that's against biopsies these days, we recognize this is all about educating the patient that they have to change their lifestyle. So prognosis of NAFLD is generally good as long as you can get the patient to engage with that. And liver biopsy doesn't necessarily get you there. But it is really, really important to educate. So here you are with your obese patient, you found those liver enzymes, and you want to be confident. Look, I was worried about your liver. I'm going to check a whole bunch of labs to make sure I fully understand your liver, but we've got to deal with this. So, what about cirrhosis? Well, when you have liver failure, the liver is simply not functioning. When it's completely dead, it's not doing what it needs to do. And it's certainly quite an extraordinary looking organ when you see a cirrhotic liver. And again, I like to show patients pictures. This is what I don't want your liver to look like. So I think most important is to remain hopeful. You really want to impress on patients that, okay, I found this and we have to reverse this disease. We need gradual and sustained weight loss. And to do that, we have to engage in healthy lifestyles with parents and kids, eating more fruits, veggies, whole grains together, sitting down as families, basically limiting junk food and exercising, really going for that exercise is a big piece for these kids. We want a balanced, calorically appropriate diet, increase physical activity, and it's really helpful to engage the entire family. And I wrote here hint, hint, because one of the questions in the MOC part 2 gets at this. But it's really, we know family-based therapy for obesity, family-based nutritional therapy is really the important when trying to tackle childhood obesity. So in terms of changes you may want to make in your practice, I do think you should screen all children who are obese for NAFLD. That's the AST/ALT. If you find that you need to pursue assessment, you absolutely can refer them to me, but really I'm showing you what I do, which is to look for all those labs, make sure I'm not dealing with anything else, and then really focus on educating my patients about NAFLD. And in the end, the most important thing to do is to start treating the obesity, to start talking about it and dealing with it. And I'll end there by thanking you all for listening and giving you that pep talk. You too can be confident.